I'd like to, first of all, begin by welcoming everyone. Our usual Cornea faculty, Doctors Hall Chu, Clara Chan, David Rootman, Neera Singhal, Josh Teichman, all of our former and our future fellows who I know will be zooming in. Special guests today, Sadir Khanush, Mike Snyder, Mark Manis, Rich Abbott, Carol Karp, Annette Galore, Rahul Tong, Buddy Culbertson, Guillermo Rocha, Mona Dagger, and Stefan Ongtong, who will be joining our Cornea group whenever COVID is over. I'd like to also thank our fellows very much. Tanya Trin, who has really, she's a second-year fellow and who's been doing a lot of the heavy lifting to get these rounds operational. Michael Mamouni and Gisela Santella, who are keep scanning and will be looking at following the chats. I'd also like to thank Alfonso Iovina, one of our former fellows, now cornea specialist at the University of British Columbia. And also, I'd like to thank Amit Rai, one of our residents who is interested in cornea and will be launching the polls. So our goal today, our learning objective, is to make this an interactive learning format. This will be recorded, archived, and will be available to be searched and reviewed in future should you want so. It really stems from a surgical video night that I've been holding for a couple of years now at my house with pizza and videos where we get together with our fellows and just go over surgical cases and benefit from each other's experience. And we're very fortunate now that we have the experience of an international world-renowned faculty. You know, it's ironic. The one silver lining to this dark cloud of COVID-19 is education. And ironically, Zoom, like COVID-19, doesn't respect boundaries. But in this case, we've been able to harness Zoom to bring in people who normally would not be able to attend these rounds. So this is our first go at it. And I'd like to thank everybody for participating internationally. And talking of which, Amrit, could you launch our first poll, please? So basically, going to want to know, I'll give about 10 seconds for this to be filled out. If you could just click in where you're polling in from, I'd appreciate that. We now have 79 people on, so 80 and growing. And okay, I think that's it. Why don't we get the results? So we can see that most are coming actually from outside of Toronto, 32% from the GTA, 11% from South America, 16% from the Middle East, and unfortunately, Australia is 3 o'clock in the morning right now, so they're not going to be launching in, although one of the fellows said they're getting up at 3 to watch this. Okay, so we can take the poll down now, and I'd like to move right on to our program. So our first presenter this afternoon is going to be Michael Mamouni, and he's going to speak about a decimate stripping only and phaco and IOL that he did while he was on my service. Just incidentally, I'd like to send a warm welcome to all our guests from Africa as well. Michael, can you take it away?
Thank you, Professor Stolvik. So why don't we get the first poll up about the decimate stripping only, DSO, the first video, question number 1. So what we're asking here is, what's your experience with decimate stripping only technique? Have you done any 1 to 5, 6 to 10, 11 to 15, or more than 15 cases?
So I think the problem is the panel cannot participate in the poll. And I think a lot of the panel is going to be doing this procedure. From the audience who zoomed in, we now have 93. Most, 85%, are not doing DSO. So this will be interesting for you. And about 12% say that they'll be doing between 1 to 5 cases annually. So
this is great. It's a great opportunity to share my first case that I've ever done of DSO. And so you can kind of examine the learning curve together with me. I'll share my screen. Great. So this is a 78-year-old lady complaining of gradual reduction in vision as well as glare. She presents with 20/40 vision, nuclear cataract, and dense central corneal guttae with good peripheral cell counts. What you can see here is that we mark the central 5 millimeters centered on the non-dilated pupil, then we ink the central 4 millimeters as well. A small air bubble has entered the AC and nicely emphasizes the central guttae for us, which you can see above the air bubble. The phaco surgery is performed as it is routinely performed without any complications. For the Descemet stripping, we increase the magnification of the microscope to get good visualization, which is essential for this step. You can see my mentor, Dr. Slomovic, pointing out where to start. Initial scoring is performed with the Gorovoy forceps. Now, when you score with the forceps, you want to try to create an initial flap that you can grab to perform your descemetorrhexis. It's important to avoid blanching of the overlying stroma, as this is likely to increase the chances of scarring further down the road. Now, as you can see, it doesn't quite behave like a capsulorhexis, and it's not easy to get the flap to peel like you want it to. Here you can clearly see the area that was stripped and the fact that I no longer have a flap to grab to continue the rhexis with. So let's give it a second shot. Hopefully this time I'll get it right. This time I'm trying to grab the edge of flap with as little stromal touch as possible, and I'm able to get a small flap going. Now it seems to want to be running outwards to the periphery, which is something we want to avoid, as it's important to limit your rhexis to the central 4 to 5 millimeters in these cases. At this stage, I've again lost the flap edge, and you can see that the nasal area superior in the photo has been stripped. So hopefully the third time can be the charm, right? Let's see, let's give it a moment. And do we have it? Eureka, we finally have a flap. Now I'm trying to make it smooth and curvilinear, similar to the way you would for a capsulorhexis. I'm using the inked markings to guide the circumference of the peeling. Since this was my first case and I'm still figuring out the vectors, I'm actually putting more pressure on the eye and moving it more than I normally would like to. We are, however, able to complete the rhexis, and you'll soon see if you carefully look that there's a small area within our central 4 millimeter marking that is not completely stripped. So we will go back in there and finish off that small little bit right there. This is followed by removal of viscoelastic material and completion of the case. Following surgery, in addition to our routine perioperative protocol of steroids, NSAID, and antibiotics, the patient received Glanatec, a rokinase inhibitor, QID, which we generally recommend for 2 months. At the 1-month post-op visit, she was 20/25 and is currently asking for DSO in the other eye as well. I think this is a good time to bring up our second poll if we can. I routinely use ROCK inhibitors for my DSO patients. Question is, how often?
And the ones who do DSO, most do not use ROCK inhibitor, whereas 19% do. And we'll have a little discussion about this after your next poll, Michael.
Great. So before the next poll, I'd like to just give a few of my take-home messages from this first DSO case that I ever performed. So I think that patient selection is critical. Basically, you have 3 Ps. You want a good peripheral cell count above 1,000. You need to remember that it requires patience both from the physician and the patient. And you need to tell the patient it can take up to 3 months for the cornea to clear. In addition, up to 15% may still require a graft later on, which is something that needs to be explained to the patient. You want to center the marking on the non-dilated pupil. It makes it easier to center. And it's important to work with high magnification, as this makes the visualization easier. Now, when you score, you want to score as lightly as possible to avoid stromal scarring. Also, the flap does not quite behave like a capsulorhexis, so bear that in mind. And we personally recommend Glanatec, which is a rokinase inhibitor, for perioperative treatment in these patients. Thank you.
Excellent, Michael. Thank you. That was a great presentation. I'm going to ask all of the video presenters if they can just add that video enhancement app when they show their videos. I'm going to just address one of the points about the capsulorhexis. it's certainly a lot different than doing your, not decimeterexes, it's a lot different than doing your regular capsulorhexis, because when you're doing your capsulorhexis, you've got the viscoelastic pushing down on the lens capsule, which makes it for a much easier capsulorhexis. Here, there's no real tension on decimet membrane, so it's a little bit more difficult. And although the tearing action is there, the vector forces aren't the same as a decimeterexis. I'd like to invite any of our panelists, if they want to make any comments on their experiences with doing decimet stripping only.
So Alan, I'll jump in first. Mike's
Thanks,
nice.
Mike.
I've only done maybe a couple of dozen of these, but the interesting thing that I found is that I expected about a third of them to fail. And so far I haven't had any fail. And some of the cases I've done had really truly frank bulle apically. And so I've really been very impressed with the ability for the endothelium to recover. I'd like to know what other folks have been doing as far as trying to estimate the cell counts. I've not been very good at being able to use an automated counter to get the peripheral counts. So I've just been kind of looking with specular reflection at the slit lamp and saying, yeah, it looks pretty good, or it doesn't look so good. What have others been doing with that?
I can jump in here, Mike. First of all, to back up a little bit, you know, when we first converted to doing DMAC, and this is for our international viewers, when we started doing DMAC, whatever it was, 7, 8 years ago, I would look at colleagues who had started a year or two before me. I would be surprised at the kind of Fuchs involvement, if you will, or guttate involvement for which they would choose to do DMAC. And because for years we were taught, and we taught our residents and fellows, that guttate changes on the posterior surface of the cornea are not visually significant in the absence of edema. So now we know they are visually significant, and even moderate guttate changes are significant. Nevertheless, the beautiful case that Dr. Mamouni showed could have been approached with a staged manner, doing the cataract first and seeing whether the patient was happy with cataract surgery alone, and then deciding whether to proceed with a DSO. That being said, I think Dr. Snyder's comment is very important. I have never been able to use my specular microscope to evaluate the peripheral cornea. So when Dr. Mamouni says 1,000 cells or more, yes, that's nice to have, but unless you're using a confocal microscope to do that, you know, it's a gut feeling. You look at the peripheral cornea, it's free of guttate, and you use the technique that we were all taught when we were fellows 30 years ago, specular microscopy, basically through the slit lamp to estimate the cell count. So that being said, leave it to other people to comment, because I'm sure, Alan, you have other questions regarding Riposidil and other things.
I was one of the probably early adopters of this technique. I performed my first cases of DWEC DSO, I think in 2015. The challenge that, and we published one of the early, very small series. One of the challenges that we had at the time was that we were performing decimeterexis by scoring decimate with the reverse Sinskey hook, and that resulted in some sort of posterior stromal opacity, which then created irregular astigmatism in 2 out of 5 patients that were part of that series. So technique has definitely made you know, a large improvement to the outcomes of this surgery. The one element that I would like to sort of pick your minds about is whether you would consider entertaining this type of surgery in the absence of a ROCK inhibitor postoperative treatment. Because the challenge for a lot of countries is that COA will not deliver there, or whatever pharmacy you use, patients don't can't really get these drugs. And in the absence of these drugs, my personal experience is that results can be rather unpredictable.
Excellent point. I agree with you. I don't think I would use it without Glanatech. I started the day of surgery, and I continue it for 4 months with a slow taper. I get it through the Mamaki pharmacy. I have the patients get it themselves, and I give them the website, and it really has not been a problem. I know that Maloney, in his initial trials, he rescued two DSOs that had failed and that cleared using Glanatec. So I think, as you point out, there's a really important role for it. You know, I got the process from Dr. Gorovoy, and I'd be happy to share it. You know, the patients just go directly, because we can't get it here, and they go directly to the Mamaki Family Pharmacy in Japan. They send it to the patient. We've not had a problem with it. It's worked pretty. In fact, my secretary handles all the paperwork with that. So I agree. I wouldn't do this without Glanatec. And Sadir, your comments are really well taken too. We just got a specular microscope after this case was done that will allow us to look at the periphery. I haven't really had a chance. Then we got COVID, and haven't had a chance to play with it to see how good it was at taking peripheral photos. But a lot of the times you can just see on slit lamp exam, you know, if they've got 4+ central guttata, and the periphery, using your specular microscopy skills at the slit lamp, you can appreciate that there are cells peripherally. So that's been my experience. Anyone else have anything else they want to add?
Alan, hi, nice to see everyone. Alan, my experience has not been as broad or as motivating. I've just had one patient, highly motivated patient. I did all the right things, and I actually had just come back from visiting Mark Gorovoy. I had his forceps, followed everything to the Q. In fact, if I may just briefly share my screen, I saw this kind of pattern, the pattern with the honeycomb pattern that you can see following the procedure, and you can almost see here the edges of the DSO, or the descemetorrhexis. So in spite of the treatment, high motivation, good compliance, the problem was it never recovered. It ended up doing a DMEC afterwards with a good result. I think there's a lot of promise, and I think the big challenge is determining which ones are the good candidates and which ones, by looking perhaps at the genetics, perhaps at the periphery, perhaps at other factors that we may not be aware of, which ones are the ones that are going to be the successful ones.
You know, we know there's a 15 to 20% failure rate, even with Glanatec, maybe a little lower with Glanatec. How long did you give it before you did your DMEC?
We did 4 months.
Oh, that's certainly long enough.
Yeah.
I wait about 3 months before I move on. You know, but still, that may have been just by the luck of the draw. It may have been one. Also, an important point in our patient was that she also had some stromal edema and a diurnal, fluctuation in her vision. So you can detrogest that. And she actually ended up with excellent central vision, 20/25. Mm-hmm. She's not on any steroids. We got her off after about 6 weeks, and asking for the other eye. Not, you know, I have 2 that are going on to DMEC. So it's not a perfect science.
Yeah.
Alan, can I jump in to just say one thing about Repasidil? And I hate to bring the hydroxychloroquine analogy with COVID-19. I know it's a very controversial topic, but we have to decide, many of us, I'm sure on this panel, feel that there's a role for a rho kinase inhibitor, and specifically Repasidil versus other rho kinase inhibitors. As you know, in the United States, we have the glaucoma drug, Repressa, which is also a rho kinase inhibitor that some feel may not work as well for DSO, for helping proliferation of the peripheral endothelium. But, you know, there's not been a study yet. Well, there have been some anecdotal work. Marion Maxley showed some stuff, but there's not a countrywide study evaluating Glanatec or Repasidil versus no Repasidil. So we're hoping to start that study after COVID, and we're going to be double-blinded. We're going to randomize, you know, Glanatec versus placebo.
Cal is sponsoring that study, aren't they? Yeah, no,
that's correct.
I mean, that's a good point. You know, we need level 1 evidence, which we don't have. These are just anecdotes. You know, in my 12 cases, can't really, you know, I've done all with Glanatec. good comment. Michael, you're monitoring the chat. Are there any other questions that we need to bring up before we move on to our next presentation?
I just wanted to ask the panel members, has anyone ever tried using the femto for their stripping as opposed to the forceps? And if so, what is your experience with it?
I'd like a comment here. I have not, neither the femto nor the excimer, but there's a paper in press from Munich, Germany by Martin Derissemer, in which they are ablating the posterior surface with excimer, the thing that we try to avoid altogether when we use the excimer. So I'm not sure exactly how they determine the depth to do that, but there is an effort to do that to make an exact rhexis, like removal of the central Decimes membrane.
You know, I'll just weigh in a touch. I haven't used femto for creating the posterior descemetorrhexis, but I do actually like to use the disposable microforceps, the Grieshaber Max Grip forcep. The 25 gauge Grieshaber Max Grip tip is very, very delicate and fine and goes in through a paracentesis from just about any angle. So it's ergonomically quite friendly. So though it costs, you know, what, 100 some odd bucks to throw it away, it's certainly cheaper than the femto and works pretty darn well.
You know, one thing I want to say is that it's really important not to rough up the fibers of the stroma. The way this works, or proposed mechanism of action, is you're getting migration of endothelial cells. There may be a question of peripheral stem cells in the endothelium at the periphery, but the major way that this works is you're getting migration of endothelial cells. So if you have any ridges or bumps or anything like that, it's going to make it more difficult. So my only concern with the femtosecond is if you're not exactly aimed on the on Decimes membrane, you may get some stromal roughening, and that may make it more difficult for migration. Tanya, I think you wanted to say something?
Yep, I was just going to say a little bit of housekeeping. For our panelists that are online today, there are a number of questions coming through on the Q&A, and if that falls within your area of expertise, I would be grateful if you could type some of those answers. It just helps us sift through some of the questions. I will bring forward some of the questions which we've touched on, but just to make a little bit more explicit, and we've got some excellent questions from Dr. Pedro Eva Navarro. He was questioning what the reason is to switch from the regular scraping technique to descemetorrhexis in DSO. And secondly, is there an estimation about how much endothelial cell function is due to peripheral normal endothelial cell movement to the center or the effect of Rho kinase inhibitors? And I'm not sure whether you covered that in your talk, Dr. Ongtone, but just wanted to bring those forward.
I think what I would like to do, Tanya, is maybe let's go to Stephen's talk, and if those questions aren't answered at the end of that talk, we'll address those directly. Does that sound okay? So okay. Our next, Stefan is just completing his second year of fellowship at the Mass Eye and Ear, and has been doing a lot of work with endothelial regeneration, migration, DSO. And Stefan, could you go ahead, please?
Sure. Okay, I'll just share my screen here, make sure. So my name is can you guys see the screen?
Yeah.
Okay, so my name is Stefan Ongtone. I'm a second year clinical corneal fellow here at Mass Eye and Ear. I just want to thank everybody for inviting me to present my research. So today I'll be talking to you about increased corneal endothelial cell migration in Fuchs endothelial corneal dystrophy in a decimeted stripping only model that we are developing. And what you're seeing here is a live imaging of GFP positive endothelial cells. So these are primary corneal endothelial cells that are migrating on their native Decimes membrane, navigating this field of Goutte. So these are just some disclosures here from our lab. So I work with Dr. Ula Yurkunis here in Mass Eye and Ear. And so I'm going to be talking to you about a little bit about Fuchs endothelial corneal dystrophy. It's the most common disease infecting the corneal endothelium. We know that it's a genetically heterogeneous disorder with TCF4 repeat expansion being the most common. And it's characterized by the formation of corneal guttae, and it's purified by the collagenous deposits. And it's also defined by corneal endothelial cell apoptosis. And we know that there's, as we've been discussing, that there's this regional variability where it seems that the center of the cornea is a lot more affected than the periphery. And we can take advantage of that through surgically. So we know that there's DSEC and DMEC. And as we were just talking about, now that we take advantage of it with newer techniques such as decimate stripping only, also known as DSO, or DWEC, decimate stripping without endothelial keratoplasty. And in this case, as we just saw in the last video, a central descemetorrhexis is performed, and it really takes advantage of this ability of the peripheral healthier endothelial cells to migrate and repopulate that central area where the descemetorrhexis was performed. So really, since this whole process is really contingent on endothelial cell migration, the purpose of my research was to study corneal endothelial cell migration in Fuchs. So the methodology that we're using is a live cell imaging of cellular migration in Fuchs, and we use comparative normals. We take advantage of these immortalized cell lines that we've developed using low cell density and high cell density conditions. And we also take advantage of ex vivo specimens. So these are specimens that are from Fuchs patients undergoing typically DMEC, and we take the strip tissue and take it directly to the lab to study, and we use donor controls to compare. And we look at low cell density and high cell density. And last, we're developing a decimate stripping only model where we can investigate cellular migration. And the way that we quantify the cellular migration is we use this automated analysis of cellular migration using this TrackMate plugin, which I'll go into a little more details afterwards. In terms of first, for these corneal endothelial cell lines from Fuchs patients, the way we immortalize them is that we take this stripped tissue from Fuchs patients undergoing DMEC, and we take it directly to the lab, and we can immortalize them using this SV40 virus. And what this allows us to do is generate a lot of different cell lines from different patients, from different ages and different sex. And we also collect blood at the same time, so we can actually genotype them. And in this case, specifically, we're looking at the TCF4 repeat expansion. So for the purpose of this talk, I'm going to be focusing on two cell lines that we've generated. This 54, one from a 54 female and a 74-year-old female. One has this TCF4 repeat expansion, whereas the other one does not. And we compare it to normals. So I hope you can all see these movies over here. So what these are cell lines that have been plated at low cell density conditions. And what you're seeing here is that there's normal cells compared to the two Fuchs cell lines. And this here under the Fiji TrackMate here is showing you how we automatically quantify this cellular migration. Sorry, I just see there's a chat here. I just want to make sure everyone can hear. Okay. Can everyone still hear me here?
Mm-hmm.
Okay, sorry, I wasn't sure if anyone. Okay, so when we quantify this, the cellular migration speeds under these low cell density conditions, we see that there's normal, and we notice that the two cell lines, the two Fuchs cell lines display increased cellular migration speed, and this is the quantification here, and these are the actual numbers. So these are under low cell density conditions, but what about high cell density conditions, or a monolayer, which is typically how the endothelial cells are actually formed in vivo. So to assess this, we perform a scratch assay. So what we do is we grow the cell lines under high cell density conditions to form a monolayer. We perform a scratch or a wound edge, and we live image them over a span of about 16 to 24 hours. And we watch these cells actually close that wound. So this is a movie here. So these are movies looking at normal and the two Fuchs cell lines. And there's images taken about every 2 hours over a 16-hour, 18-hour time period. And what you see is that with the normals over this 18-hour time period that the wound doesn't close, but in the two Fuchs cell lines, you have increased cellular migration, and there's almost complete wound closure by the time of 18 hours. And this is the quantification down there. So this is all in cell lines. So what about actually in these ex vivo specimens? So, we take advantage of a technique because we found it very difficult to actually track and determine migration speeds without actually transfecting with GFP to label them. So what we do is we get these Fuchs cells, these Fuchs specimens from patients undergoing DMEC. We take the strip tissue, we take it to the lab. We actually transfect them with this lipid nanoparticle technology that gets all the endothelial cells to express green fluorescent protein. So what you're seeing here is this is the entire strip tissue, a phase contrast image, and then these are all the labeled endothelial cells here in green. And we can image these under higher magnification conditions to determine the migration speed. So this is the experimental protocol. So we're taking Fuchs specimens and also comparing to normal specimens. And we're imaging them under high cell density conditions and low cell density conditions in both Fuchs and normals. And just a reminder here that this is a phase contrast image of a specimen where centrally all these little bumps here is this confluent guttae, whereas in the periphery you get this reduction in the cell density, the density of guttae, and therefore increase in high cell density of endothelial cells. So this is actually I want to show you this. This is actually one of the first movies that I took. So this is a Fuchs specimen. So you can see that there's all these guttae here. These are all the labeled endothelial cells that have been labeled with GFP and acquired a movie over about a 16-hour time period. And to my surprise, a lot of these corneal endothelial cells were actually displaying, they were quite motile, and they were moving a lot in terms of navigating through the fields of all the guttae here. So it was kind of counterintuitive to what I initially expected. I thought they were going to be a lot slower. But so now if we specifically look at these high cell density conditions, so we're looking at a normal compared to Fuchs. So this is a high cell density condition. And you see that there's some movement, the cells moving around. They're quite dynamic. But in terms of actually moving around and migrating in different locations, we didn't really see that. There was no difference between normal and Fuchs. And I think that's because of the cell-to-cell contact inhibition. In contrast, when we look at these low cell density areas, so here on the left side, you're seeing a normal specimen, and here on the right side, you're seeing a Fuchs specimen, that compared the Fuchs compared to the normals, that I noticed that these Fuchs cells display increased cellular migration speed compared to normals. And this is the quantification here. So there's kind of two take-home points here. If you compare normals, high cell density to low cell density, or also Fuchs, high cell density to low cell density, that there's a clear increase in migration speed when you go from high to low cell density conditions. And when you can specifically compare the migration speeds of normal cells compared to Fuchs cells, that these Fuchs cells do display an increased cellular migration speed compared to normals. And I'd like to show you this. So this is still preliminary data of so all this, the live imaging in these ex vivo specimens is on their native, they're migrating on Descemet's membrane. Whereas in DSO, what we're doing is we're actually performing this metarexis, and these endothelial cells are migrating onto bare posterior stroma. So the model that we've developed is actually we take a stroma. So in this case, we've taken a dissect button, remove the endothelium, and we've laid it down. And what we can actually do is take this stripped Descemet's membrane tissue from a Fuchs patient and overlay it onto the bare stroma. And the idea behind this is that we can watch these endothelial cells migrate off of Descemet's membrane onto bare stroma, which is more representative of what happens in Descemet stripping only. So this is some preliminary movies that we're still optimizing this technique here, but you can see that these GFP labeled cells here are migrating. So here's the edge here of the Descemet's membrane, and here's the bare stroma, that they're migrating off of their native Descemet's membrane and onto the bare stroma. So the question is, why do these Fuchs cells display faster cellular migration speed? And our lab has done a lot of work in identifying oxidative stress and mitochondrial dysfunction in the pathogenesis in Fuchs. But one of the, there's many different things that have been implicated, but one of my hypothesis is that this EMT, this endothelial to mesenchymal transition, is very important for this phenotype. And in actuality, when we look at some of these protein markers for EMT, when we look at them in Fuchs compared to normals, that and we look at markers such as EDCADHERE, fibronectin, SNAIL1, and smooth muscle actin, which are all EMT markers, we see that there's increased expression in Fuchs. So the next question is, why do Fuchs cells undergo this endothelial to mesenchymal transition? And this is my current hypothesis. So if you look at here, a normal ex vivo specimen, and you stain it for F-actin, which stains the cytoskeleton, it really shows this compact and really well-defined monolayer of these corneal endothelial cells. In contrast, when you look at a Fuchs specimen, a lot of these Fuchs cells now are displaying this fibroblastic morphology, where you see that they're a lot more spread out here. And I think that's the process is that as these Fuchs endothelial cells undergo apoptosis and more of these cells die off, the residual cells there's a selection pressure that they actually want to migrate and actually form a monolayer. So there's this drive and almost a selection for these cells to spread and almost become dysplastic and fibroblastic by this process. So in summary, developed this novel live imaging system to study endothelial cell migration. We've generated these immortalized Fuchs cell lines with and without this repeat expansion, which are very valuable tools to study the pathogenesis of Fuchs. Through this research, I've shown that these Fuchs cell lines display increased cellular migration under 2 conditions. And then also this increased migration phenotype that we're seeing, we also see in ex vivo specimens, especially in the low, and particularly in this low cell density conditions. And these Fuchs cells display this pro-migratory phenotype, and that this may represent an endothelial to mesenchymal transition. And really, my goals are to understand this endothelial to mesenchymal transition and its role in Fuchs pathogenesis. So some of the next steps that I have in mind in terms of the research is like, how does, what else affects migration speed? There's in interplay, we know that, endothelial cells, they sit on Descemet's membrane. So how does the central versus peripheral location affect migration speed? And what about glutate density? If you have a denser, is that inhibitory, or is that actually more pro-migratory? And how do the genetics function onto migration speed? And how does the function of TCF4 specifically affect that? And that's, I think, particularly important when we talk about clinical treatment of going forward, in determining the selection of, which candidates are ideal for DSO. Maybe the future is that we genotype these, and depending if you have this TCF4 mutation or another mutation, they may be a better candidate for DSO. And obviously, ROCK inhibitors, as we're talking, is very topical now. And how do these affect, migration speed? And how does it affect it depending on your genetic status? So I'm particularly interested in exploring these mechanisms that lead to increased cellular migration in Fuchs. So I just want to say thank you to so I spent the last 2 years in Dr. Ulla Jakunis's lab, and a lot of this work was done with my collaborators here, which are highlighted. So thank you very much for your attention and this opportunity to present my research, and I'm very happy to take some questions.
Okay, Stefan, that was excellent. Can we put, okay, there we go. So I guess one question, first of all, we're all looking forward to welcoming you back after COVID-19 and looking forward to interacting more with some of the research you're doing. Question, is there any evidence from what you're doing that there's a benefit of one ROCK inhibitor versus another ROCK inhibitor? And what's the optimum frequency and duration of treatment?
Right. So in terms of the research, I mean, we actually are, that's one of our next steps is we actually have some funding to, we're working with COA to kind of look at some of these ROCK inhibitors, and we're hoping to troubleshoot and identify, some potential ROCK inhibitors in these ex vivo models that can give us some data to maybe go into in vivo to actual patients. I would mirror what I think it was Dr. Snyder was saying before. I think anecdotally here, we've used Ropressa after DSO, and I would say that the people doing here, Dr. Pineda and Dr. Kunis, I think their impression has been that it hasn't been as robust as some of the reports of patients using Glanatech, and we actually get some of our patients to order it from Japan directly, so they can get Glanatech rather than Ropressa.
Thank you. I think in the interest of moving on, any other questions? I'm going to pass my summary of the DSO and just move on to the next case. Any other questions for Dr. Ong Tong before we do move on? Okay, Stefan, I really think that was excellent. We're looking forward to some of the new work that you're doing, and we'd love to work with you. And you have to keep us abreast of how your research is going. So
Thank you very much again for this opportunity.
Thank you. Our next speaker is going to be one of our former fellows who's now a cornea specialist at the University of British Columbia. Dr. Alfonso Iovino is going to speak to us about lamellar keratoplasty and cataract surgery. Alfonso, do you want your first poll up now?
We could do it before, we could do it even after the talk, I would say. Maybe let's do it before, that's fine. Let's bring it up.
So when performing lamellar keratoplasty in a cataractus patient, do you perform phaco before lamellar keratoplasty, after, simultaneously, or depending on the case? Do. We need the music. Okay, let's see what the results are. So it depends on the case. I think that's going to be discussed in your talk. The next most common is before lamellar keratoplasty, followed by simultaneous, and 5% saying after lamellar keratoplasty. Okay, so let's go to the next question. I believe you had a second poll, Amrit?
I can go on and start the presentation now, I think.
Okay,
maybe
we can do the polls afterwards.
Also save some more time for discussion, which I'm sure it's going to be quite interesting after this. So let's see. All right. Can you guys see my screen?
Yes.
Perfect. So first of all, thanks for the kind invitation. It's always good to see familiar faces and new faces of the extended Toronto family. Although the definition of Toronto family really applies to me and my wife, being the only two former fellows who actually started a family and had a baby, who's the 2.0, I would say, Toronto fellow for the years to come, maybe, who knows. Anyway, so we'll take it down a notch and we'll start talking about, this is a presentation that I've given for the Italian Cornea Society. This is our bread and butter, combined the phacoemulsification and endothelial keratoplasty. This is more for the interest of fellows or young surgeons, but I'm sure that there will be a lot of discussion after this as per our difference in patterns when it comes to this specific issue. No financial interests. So we've been witnessing a phenomenal shift in expectations when it comes to postoperative vision in patients after cataract surgery over the last, I would say, 4 decades. This is what's marketed in our present times. And to a certain extent, a similar thing has happened also for cornea transplant. 20 years ago, a successful cornea transplant was a good vision with an RGP. Now, endothelial keratoplasty in particular, and the DMEC above all, the DMEC boom, has brought a whole new understanding of visual recovery and expectations in our cornea transplant patients, to the point that, to a certain extent, 2020 seems not to be enough for our patients. So I'm really going to focus here on endothelial keratoplasty and cataract, and specifically patients with Fuchs dystrophy. So that fits quite well with the very interesting and cutting-edge presentations that we've heard before. So there are essentially 2 scenarios here. In the first scenario, there's a patient that comes to your clinic and the patient has Fuchs dystrophy and a cataract. So there are definitely advantages to combining endothelial keratoplasty with cataract surgery. It's only one surgery, reduces the costs, reduces the risks, is definitely more amenable to the patient. And studies have shown that the intraoperative or postoperative complications of the 2 operations combined are not higher. There are some cons on the other hand. We know that we are more prone to IOL calculation error in combined surgery. We can offer to the patient premium IOLs to a certain extent, and we'll look into that. And some people have raised the concern of eliciting cytokine storms, a very fancy expression these days, when we're doing cataract surgery with endothelial keratoplasty that could possibly harm the endothelial cells. So the use of DSEC in endothelial keratoplasty for Fuchs dystrophy has legitimately to be considered the past. In the DSEC era, which is the past, we used to offer endothelial keratoplasty later to our patients because the visual outcomes of DSEC were less reliable when we compared them to DMEC. So in general, the course of action, most of the time it was the following. So when a patient was coming with mild dystrophy, we would do the cataract extraction first, eventually followed by a DSEC if the visual recovery was suboptimal. And when the dystrophy was moderate to severe, then we would perform combined surgery. So relatively straightforward. The present times have changed somehow this paradigm with the introduction of DMEC. DMEC yields way more predictable visual outcomes. Some say better. I would say more predictable is a more accurate of describing them. And now we feel more comfortable offering endothelial keratoplasty earlier to Fuchs dystrophy patients. You can see there's a video there of a DMEC performing cataract extraction, nothing out of this world, again, your day-to-day life. What this generates in patients is that there are definitely though higher expectations. These are patients with better visual acuity. They're less tolerant to errors in calculating the intraocular lens. And there are patients that come to us and ask for premium IOLs. They want the same IOL that the neighbor got that allows her to see distance and near and whatnot. So let's look into what happens to IOL calculation in triple procedures with endothelial keratoplasty. Now, in DSEC, we know that there's a moderate hyperopic shift. And this hyperopic shift is a result of the resolution of the central edema combined with the negative lenticule effect of the DSEC graft. For this reason, we aim at a postoperative target of -1 to -1.5, depending on previous studies. And some have advocated also an adjustment in the K readings. With DMEC, on the other hand, the hyperopic shift is modest. There's no negative lenticule effect, so it's only due to resolution of central edema. And in general, there are two schools of thought. There are people like Price has shown in this study who would correct for about a -0.75 hyperopic shift. And there are others that say that the reversal of the myopic shift induced by edema is actually as a total sum of 0. So essentially they advocate for aiming for plano. We've done a little study of our own cases. We have 70 cases of DMEC phaco. Surgeons here aimed for a target of -0.69, and this is where we ended. So 41% of patients were within 0.5 diopters from plano, 63% within 1 diopter. So not great in a way. The cutoff for identifying patients that would have more of a hyperopic shift seems to be 640 microns. To further complicate things, some patients after DMEC will even develop a myopic shift, which is even more difficult to take into account. What happens to the corneal topography after a DMEC? And this is a patient of mine in which, as you can see, 6 months after DMEC, there's a substantial regularization of the corneal astigmatism with a reduction in the astigmatism value as well. So corneas after DMEC, they tend to be thinner in the center than normal corneas. They have a steeper pachymetry progression if we look at the Scheimpflug maps. And the correlation between anterior and posterior astigmatism seems to be lost. So our biometry can be not the most accurate. There are changes in the cornea which we cannot entirely account for. So some surgeons or cornea specialists have then proposed to go back to a PK habit, which is to do the transplant first, followed by the phaco, and use the cataract extraction as a way of correcting or fine-tuning the visual acuity after the transplant. So this could be applied to DMEC as well. In fact, doing a phakic versus a pseudophakic DMEC seems to yield similar outcomes. The endothelial cell loss with the soft shell technique cataract extraction in DMEC patients is minimal, as it is the risk of graft detachment. the IOL calculation would follow standard rules after the DMEC, and that would allow us to use toric and presbyopia correction intraocular lenses. How do specialty lenses perform in DMEC patients? There's not a lot of literature in this case. There's a study from the Terry group in which toric IOLs were employed at the time of DMEC surgery. So this is DMEC triple with toric IOLs. And as you can see, results were not particularly exciting. 60% of patients only better than 20/40. And in 4 out of 13 patients, the astigmatism flipped from with the rule to against the rule. On the other hand, the use of presbyopia correcting IOL, specifically bifocal and EDOF, in this study by Price and co-workers, this is after DMEC surgery, so not at the same time of the DMEC surgery, seems to be quite effective and reliable. So the question that a lot of us are asking ourselves in this day and age is that, is there still a role of just doing cataract surgery in patients with fuchs dystrophy? And I personally think that there might be. There are patients who are adverse to endothelial keratoplasty or cornea transplants in general. In absence of circadian variation and a normal central corneal thickness, when we expect a lack of compliance from the patient, although DMEC is probably the more non-compliant friendly of our transplants to date. And when there's reduced visual needs, then cataract surgery solely could be proposed to these patients. Some have looked into the predictors of needing endothelial keratoplasty after cataract extraction in fuchs patients, and they seem to be quite simply central corneal thickness or the light scattering you get from the anterior layer, either at Scheimpflug or confocal microscopy. And we've heard before very eloquently examined the potential role of DSO or DWEC in cases like that. Then there's the second scenario. Patient has fuchs dystrophy, but it doesn't have a cataract. How would we behave in this case? We've seen before that phakic and pseudophakic DMEC have similar outcomes. And we know that DMEC is a risk factor for the development of cataract. The percentage of patients that develop a cataract after DMEC is variable in the different studies, but seems to be definitely higher in patients over the age of 50. Another thing that we have to consider is the preservation of residual accommodation, which is very dear to some of our younger patients. By performing cataract surgery, we strip them of any residual accommodation that there is, and this may not be very amenable to some. What's the role ultimately of doing phakic DSO or DWEC? And that's a question that's open to the panel and the participants. Now, bonus content, just a little note about what we do in case there's an anterior chamber IOL when we perform endothelial keratoplasty. And I'm just going to show you a couple of videos. In the first video here, I proceed with removing the anterior chamber lens, and I position a secondary IOL with the Yamani technique. You will see here that my hand shaking progressively increases throughout the case, and this is just a proxy of what's happening in my chest. Like all of my Yamani cases, very sort of nerve-wracking, but ultimately the case goes well. The lens, once it's in position in the sclera, it's very, very solid and definitely allows endothelial keratoplasty, which is conducted in a standard fashion. And in this second case here, there's some delay in the video, but essentially there's an ACIOL and I'm just putting the Dissection graft above the ACIOL. So you would ask then, what's the difference between these two cases? And one may say, well, the visualization was better in the first case than the second case, but ultimately the difference is the age of the patient. So as corneal surgeons, the ACIOLs are arch enemies. Personally, what I believe is that any unnecessary hardware that's present in the anterior chamber has to go at the time of endothelial keratoplasty. But obviously, this has to be done with a pinch of salt and individualized on a case basis. So my take-home points is that, as often happens, there's no one fits all, but a tailored approach to every patient is what suits us better. When there's fuchs dystrophy with a significant cataract, I would offer a DMEC triple. If the patient is generally okay with specs and wants only one surgery, I would offer a DMEC followed by cataract extraction if the patient is fiercely fixed on spectacle independence and doesn't mind 2 surgeries. If there's no cataract, but only fuchs dystrophy, if the patient is younger than 50, I would do a phakic DMEC. If it's older than 50, I would behave as if there was a cataract. And lastly, the ACIOLs, I personally remove them in most of the cases, in particular when the patient is young and has no comorbidities. But again, this has to be sort of customized to the patient's need and expectations. Thank you very much.
Thank you, Alfonso. That was fabulous, and lots of room for discussion there. So I think we would just go right to our discussion. I'd also like to welcome, as part of our panel, two of our former, one of my mentor when I was at Bascom Palmer, Buddy Culbertson, and also I understand Sonia Yu is on. So feel free to join the conversation. And you know, you talked about the hand mirroring what's happening in the heart. For our next rounds, I'm going to ask one of our former fellows, Randall Ulati, who probably has more experience with Yamani than anyone in the world, who presented at the AAO a case where he did a DSEC implantation of an artificial iris combined with the Yamani procedure. So Randall, please start getting that case ready. I think it's, you know, it's the new triple. If you would do a DMEC, if you would use a multifocal lens in a DMEC, would you do your DMEC first, get stable refractions, and then do your multifocal? And if you would you use an EDOF versus either bifocal or trifocal?
I must say I have very limited experience in that sense. The only IOLs that I've used, and I have probably like less than a handful of cases, were EDOFs, and I've used them all well after the DMEC procedure. So I've done a DMEC, I let the patient settle for several months before proceeding with cataract extraction. I'll be interested in knowing what everybody else thinks.
Any of the panel members want to comment before I volunteer? One of you guys.
I'll pipe up. I personally haven't used any diffractive IOLs or multifocals in these patients, because I really think in those circumstances you really need perfect optics, and I don't think you can count on it. Although if I like your approach of doing, if the patient's insistent, to do the DMEC first and then see how good their optics are. It's a bit of a judgment call. But I guess the other issue, you're talking about premium IOLs, does that include torics? And I think that if you're going to use a toric in that instance, you can do it as a combined case, but everything's got to line up. They have to have pre-existing astigmatism as proven in their glasses, preferably, and hopefully their topography will correspond to it, because we've seen several Fuchs patients who have corneas. We've even had patients who look like they have keratoconus, and then you do their DMEC, and of course the inferior steepening and the astigmatism disappears, and it just turns out that they were a normal Fuchs patient. So if you are going to use a toric lens, then you've got to have some historical alignment of all the parameters. So that would be my approach. I haven't had honestly, I haven't had a patient come. I think in Vancouver they're a little more hip than they are in Toronto, but I haven't had a patient with Fuchs that's come and said, gee, I really want to be able to function without my glasses. So, but hopefully we'll have someone that we can broach the bridge with.
Fortunately, there are not very many.
Buddy and Sonia, do you have any comments in that respect?
This is Bud Culbertson. We've come a long way since the good old days when you were a fellow, right?
Yeah.
Yeah.
A long time.
Looks like you're in the OR.
Yeah, no, not exactly. I'm just sitting on my couch in my office. But
Huh?
when you think about all this technology and insight we've had over these years, but it just does seem like yesterday. But I wouldn't. My rule of I would totally agree with David and everything that he said. I wouldn't wouldn't use a multifocal lens on anyone that has anything else wrong with their cornea, because you're already dealing with some multifocal optics, etc., and you try to add some other little problem with it that's particularly unexpected with some evolving cylinder or whatever, you can just end up changing a wonderful result into a unsatisfactory result with the patient.
That's why they say the enemy of good is perfect. What would you do with respect to a toric lens? Would you consider trying to take care of their astigmatism? And how would you do that? Would you do the DMEC first? Clearly, you're altering the relationship to the anterior and posterior curvature of the cornea, and that could affect your calculations for the toric lens.
Well, just like what David said, I mean, as long as the cylinder that you're estimating at the time of the surgery aligns with what their cylinder was in their glasses, for instance, historically, and it's significant, let's say it's 2 diopters or so, then if you can just debulk that cylinder and get it down to half a diopter, 3/4 of a diopter, you've really done the patient a great service. But you got to be careful that you're not dealing with kind of pseudo regular astigmatism on the topography when you make plans to do it. But I've done it regularly in endothelial keratoplasty.
Sonia, can I ask you
that's the suggestion of considering these lenses, whether they're toric or presbyopia correcting lenses, only after the execution of endothelial keratoplasty and DMEC solely. So once the patient has essentially achieved a stable cornea with a stable astigmatism, those are the only cases. I would not consider personally doing those lenses as you guys have pointed out at the time of endothelial keratoplasty.
Sonia, this is directed to you, Sonia, you. Have you had experience using Aura in some of your DMEC cases, or DSO or DSEC?
I haven't really used Aura. I mean, I would say that, you know, my patient population probably tends to be, you know, patients with a little bit more, more than just Guttata. So maybe not the best patients to consider for premium lenses. And, you know, I would also be very careful with even toric lenses in these cases with DSEC, which I think Alfonso mentioned. You know, you're changing the curvature of the back of the eye, and although they trend towards a hyperopic shift, when we looked at our data, there was a fairly large range, so that some actually ended up being myopic, and the range was pretty big. With DMEC, you have less of a refractive change, but a lot of times you'll see a little fold or, you know, wrinkle that can cause some irregularity on the back surface. And so I tend not to use the premium lenses in these cases.
What's your go-to lens?
I'll use a 3-piece acrylic lens, and I put it in the bag, and I like to use the larger optic lens so that it helps to keep it in the bag during the manipulations.
Mm-hmm. Why a 3-piece?
Well, I like the larger optic, so the 6.5 millimeter optic, and then that allows it to stay in the bag a little bit easier. A lot of times you're flattening the chamber, or you're losing fluid out of the chamber. And so if you use a smaller optic or 1-piece acrylic, it has a tendency to want to come out of the bag. So my preference is for a little larger optic.
Alan, can I make a comment?
Please.
Yeah, so what Sonia said is really important. There's only one 6.5 millimeter diameter foldable lens on the US market. And it's good to know that because it has some potential advantages. But I really wanted to kind of piggyback on what Buddy and David said. Alfonso, you gave an amazing talk and you covered so much territory. But the one thing I think that is maybe advantageous, and this may not be appropriate for an academic discussion, but I'll say it anyway, especially for the trainees who are on this Zoom conference. If you are in consultative medicine, and depending on your practice setting, and people on this conference are in different types of settings, there's only so many times you can recommend to a referring ophthalmologist who's sending you a patient with Fuchs and a cataract that a triple procedure is the way to go. And, you know, after 2 or 3 times, you're not going to be hearing from him or her again. So you know, everybody's assuming that the cataract is yours to do. And yes, if that's your practice setting and the cataract is yours to do, then you can intellectualize the staging or the combination, which lens and so on. But frequently that is decided by the referring ophthalmologist. Not that you would compromise the interests of the patient, but it is not uncommon for a referring ophthalmologist to say to you, you know, David, why don't you do your DMAC? And I would love the patient to come back to me for the cataract, or vice versa. Do you mind if I do the cataract first? And if they're not happy with their vision, and of course, Dr. Rootman nicely writes in his EMR note to the referring doctor, I'm sure the patient will do very well in your excellent hands, and I'm available to do their endothelial graft if need be in 2 or 3 months if the cornea doesn't clear. So that's a dynamic that's important, I think, for those of us who are in types of practices where we may not always have the cataract to do.
It's interesting because Gerrit Mellis in Rotterdam, who of course is, I consider him the father of everything that we're doing here today, you know, he has exactly the same approach, is that in his environment, the general ophthalmologist would like to do the cataract, and so he rarely does triples, if I'm not mistaken. Our environment in Canada is a little bit different, I think, but you make great points, Adir, and of course, being respectful of our referring ophthalmologists is one of the things that I learned from my mentors, and I think you have to take it into account. Fortunately, in Canada, there's a plethora of cataracts, so we rarely run into that kind of conflict. Most of the time, the referring doctor will say, no, I'd rather it be on your shoulders than on mine if the cornea should fail. So, but great points.
Good. I think we're, in interest of time, we've had some great discussion. Alfonso, it falls back to you. Do you want to leave us with 1 pearl or 2 pearls, 3 pearls of your talk before we move on to the next one? Is there anything you want to?
I think, you know, if I had to summarize, you know, like the key message of my talk, as well as the contribution of our, you know, very valued panelists, is that when it comes to consideration of specialty IOLs in endothelial keratoplasty, there has to be done in very selected cases and very selected circumstances, and always with a pinch of salt. Those lenses are really meant for pristine eyes, not eyes with other pathologies.
I'm glad you ended with that. That's a point that we'll all take moving forward from this. Whereas it can be done, it needs to be done probably in a minority of our patients who've expressed a special interest in that. Thank you for a wonderful presentation.
Sure.
Moving on to our next presentation will be by Dr. Tanya Trin, who has really done a lot of the heavy lifting organizing today's meeting. We have 126 cornea specialists from around the world online. So Tanya, you've done something very special here, very right. And Dr. Trin will be speaking. She's a second-year fellow on our services at the University of Toronto. And she's going to be speaking about DALK rescue. Tanya?
Thank you very much. I'm just going to share my screen, but thank you very much for the invitation to present to the Toronto Cornea Fellowship family and friends. It is slightly terrifying, but also a huge honor to be presenting to the luminaries who are joining us today. Can you hear me?
Perfectly.
Yes, okay. So today my topic will be speaking about a rescue technique using stromal hydration for DALK. And this is a case that I performed with Professor David Rootman, and it's honestly something that is really, feels like the surgical bane of my existence. But we have a 37-year-old male with keratoconus and a past history of high drops. And we're attempting to replace his cornea with a dark procedure. We've marked our white to white, our center marking and peripheral alignment for ultrafine. And we're hoping to gauge about a 90% depth, and we set ultrafine at around about 250 to 300 microns in depth to get that 90% depth without penetrating into the anterior chamber. It's hard to see the stromal scar right, but it's just beneath that center marking. So in this case, we're fairly lucky. We haven't perforated. I'm entering with the red Meles dissector, and you can see that sudden loss of resistance at that point. And I feel that perhaps I may have entered the anterior chamber, and this is confirmed by a drop of aqueous that oozes out from that wound. So we attempt the process again. My angulation is a bit steep to start with. I'm lowering the heel of my instrument, applying pressure and trying to create a small tunnel to try and attempt a bubble technique if we can. At this institution where we were operating, we only had access to the curved tan cannula, and we're attempting a bubble technique here. After I've switched hands, I'm applying pressure, and at this point, we've clearly not been very successful at achieving a big bubble technique. So at this stage, we decide to retreat. And I'd probably pause the video at this point, and if Amrit, you could bring up our first poll, is that if you don't get a big bubble, what is generally your next step? Do the surgeons here, are they more likely to convert to PKP? How comfortable are you with proceeding with a manual dissection still, despite the two potential areas of perforation?
Okay, we'll share the results. So 80% of our group, of our luminary group of cornea people would continue dissecting to Descemet's membrane using a microbubble technique, and 20% would convert to PKP. Tanya, do you have the enhanced video on?
I should do. Is it not coming across well?
Just a little jumpy.
Okay.
It's good. We're able to see it, but it's a little bit, I just want to make sure you have that on.
I'll just try this again.
So next is how to rescue, okay.
So Amrit, if you wouldn't mind bringing up the next poll. So how large of a peripheral tear will I tolerate before converting to a PKP? I'm just trying to get a feeling of the threshold at which people will convert or continue their manual dissection in a case like this.
Okay. Why don't we share the results now? And we see that the majority will tolerate a 20% tear of Descemet's membrane before they will convert. 28% of our group said they'll tolerate a 10% tear. No one in, oh no, there was 9%, 30% tear, and we must have Dr. Sarkola on the group here, because he's going to tolerate a 50% tear. Why don't we see what was done? Tanya?
Thank you. So at this stage, we're retreating, and we've decided now in this instance to convert to manual dissection. I'm approaching with my silver Meles dissector to debulk the anterior 90% of the stroma, and it's always surprising to me how much stroma is still left behind, no matter how deep I am. You'll notice at the periphery of the dissection, we are trying to leave a little bit of tissue, and that's for grasping reasons later on. The eye does feel a bit firm at this point, so we are releasing some aqueous. We already have air in the anterior chamber, so no need to add some more. After we create a little pocket going back to the red Malleus dissector, we're approaching with a 27 gauge cannula filled with BSS. And after a hand swap maneuver, we are trying to attempt to achieve a fairly even plane of stromal hydration. You can see the advancing edge of the hydration going. Has a translucent appearance. And what we will now try and do after trying to achieve as thick an area as we can is work along the borders of where the stromal hydration is thick to allow us to continue the extension of stromal hydration. And that just gives us a little bit more of a depth. You can see that the angulation is not quite right in that example, but trying to find that plane. And a good point is that at this point, we're not trying to find the plane that is above Dewar's layer. We are simply trying to achieve an even, uniform stromal hydration throughout. So there is a bit of a dance, just for my fellow trainees, between the red Malleus dissector to create the pocket and the stromal hydration. And we work our way around circumferentially until we're happy that we achieve that uniform depth. And you can see it actually tolerates and quite a lot of fluid, more than I would have expected. Now that we've got a fairly even depth stromal bed, we'll now switch again to our red Malleus dissector, and now we are trying to find that plane above Dewar's layer. And once there's a slight loss of resistance when you achieve or when you slide just into that plane, and then the sideways movement, it's a very gentle rubbing sort of sensation that you feel there's not a lot of resistance, and we're always trying to approach from the periphery to the center. So in we go with our curved corneal scissors, blunt tipped, and you can just see Dewar's layer presenting itself quite nicely there. And then we use a combination of techniques. We're partially blunt dissecting, partially moving back to our dissector at times. And we did find it quite useful to make sure that the tip of our dissector actually goes slightly beyond the vertical edge of the trephination to allow the scissors then to achieve a very vertical cut. Just to allow for better apposition of our corneal donor button. I must admit at this point I was nervous because we're approaching the area where I had initially perforated, but the aided visualization with the air bubble and the stromal hydration does help give me a little bit of added security. Now, this is just to complete the case, but our technique for removing endothelium is just to roughen up the endothelium, stain it with vision blue, and remove it with perfectly fine with the Malleus dissector. And the rest of the case proceeds with the RK marking. We place our 4 cardinal sutures, followed by the next 4 to complete our first 8. And we complete the case with a running tenor nylon continuous suture of 16 bites, which is not the focus of today's video, so I'll stop that there. So take home points at this stage is that I came from quite a conservative background with DART before I came to the fellowship, and I'd always thought that once you'd perforated, you just need to move on to PKP. But the key core is, even though we had a couple of perforations here, is not to give up too early, and that DALC is a lot more forgiving of me than I am forgiving of me in many ways. I still find this one of the more challenging operations to do of all the corneal procedures that we do. A good sized AC bubble helps with visualization, and it helps assist attachment, particularly when you do have a small perforation in that area. And that good visual results, and this patient actually ended up at about 20/60 so far, but his stitches are still in, so it's really difficult to know what he'll end up once stitches are out, but the visual results can still be achieved with a good manual dissection. Thank you.
Thank you, Tanya. That was excellent. I wonder if I could call upon our friend Sadir to comment on DALC and the microbubble technique, or just DALC in general. Any comments?
Thanks, Alan. Obviously, Dr. Trin, this is a topic that's dear to my heart. You did a beautiful job. I'll make some very rapid fire comments. Number one, great work by you and Dr. Rootman here. I'm impressed that you had the guts to try to treat fine to 90%. I think you're setting yourself up for disappointment with that much, that deep a trephination, even though you did say you only went to 250 to 300 microns. So using the vacuum trephine that you used, that's about 6 turns, 6 to 8 turns after you engage the epithelium. You mentioned the patient had previous high drops, I believe. Is that correct?
Yes.
And therefore there was at least one assumed interruption in both Decimes and the pre-Decime layer. Notice I will be very diplomatic because Harminder Dua was a fellow with us in 1994. So, and he is now starting to use the term the pre-Decime layer to avoid the controversy. So you had the initial break in Decime's membrane and Dua's plus the perforation while you were trying to pass the Mellis knife, and clearly you know why that happened. You were too deep, and the angle of your blade allowed that to happen. Now, I'm very fond of this rescue technique that you use, i.e. stromal hydration, and that thickens the cornea significantly, and then you are able to do either a layer by layer dissection or what ended up happening for you. What ended up happening for you, to me, is not an expectation. I think you were very fortunate that you created, and there is no doubt that you unroofed the pre-Decime layer. There's nothing else that looks like it except Decime's layer, and that's not Decime's. You unroof the pre-Decime layer. But that's not always what happens when you do a layer by layer dissection, even with the use of stromal hydration. It's a great technique. And the nice thing about the technique is that you can go deep enough to eventually arrive at the 80 micron residual thickness that has been described for 65 years since Professor Barraquer described this, that is consistent with better visual acuity. So you don't necessarily need to bear duas. You only have to go deep enough and leave a very thin layer, usually around 80 microns, and you should be able to graft your donor on, and that should be consistent with the visual acuity, usually in the 20/40 range, as long as it's uniform across. Those are my comments.
Thank you very much.
Thank you.
So dear, what about if you want to combine that with a cataract? Have you ever gone down like 80%, put a lens on, a contact or something to enable good visualization? What do you do combined procedures? And what's your process for doing it? How do you do it?
So in 2008, I saw an amazing video, I think 8 or 9, from a surgeon from Egypt who, to demonstrate the bursting pressure of Dua's layer, and as you know, the bursting pressure is somewhere between 500 and 700 millimeters of mercury, much higher than Decime's membrane. Now, realize, now this may have been a little bit later than 08. Until 2013, when, for those of us who are doing DALC from the mid-2000s, we thought we were looking at Decime's membrane when we removed the posterior stroma. But obviously we were not. We were looking at the pre-Decime layer. So to demonstrate the bursting pressure of Dua's layer, the surgeon unroofed it with a big bubble type 1, and then proceeded with a phaco through the limbus, all right? With a high bottle, irrigation bottle, and was able to do a normal phaco behind only pre-Decime's layer and Decime's membrane, and did it successfully. I have only been successful doing that once, but I no longer attempt a combined DALC with cataract. And the main reason I don't is because I can't predict the curvature of the cornea from my DALC procedure. So I prefer to stage the procedure, especially if the corneal pathology is greater than the cataract. I'll do the DALC first, wait a minimum of 6 months, not necessarily all sutures out, and in 6 to 12 months, consider doing the cataract procedure.
Thank you. Any other questions? Michael, I think you're monitoring the chat group. Any questions you want to bring forward? Maybe while you're looking at that, I'll ask you, Sudhir, another question. Let's say you've had an infection and you can see stromal scar, mid to deep stroma, pretty large scar, 4 millimeter scar centrally. You can't see the endothelium. What's your go-to procedure there?
Alan, I love it when the moderator asks a question that he knows the answer to. So, you know, and I'm impressed that at other times you do see the endothelium. So I never can see the endothelium. But that being said, I think what you're asking is you are not able to evaluate the posterior surface's contribution to the visual compromise. So the answer for me, at least, if there's a scar in the absence of frank edema, then I assume, dangerous word, of course, I understand that, but I assume that endothelial dysfunction is not part of the problem, and that removing the anterior 96% of the cornea, which is epithelium and stroma, should give me a good result. And if it doesn't, and the patient ends up with edema of the donor cornea, then I can always replace the endothelium behind the DALC graft. That being said, a scar presents another problem other than just the opacification. Depending on the depth of the scar, especially in herpetic disease versus bacterial infection, the scar can cause adhesions in the posterior stroma that are very close or attached to the predesime layer. And it makes the creation of a big bubble, type 1 at least, more difficult. So I will make one attempt at a big bubble, and if unsuccessful, I will do a layer by layer dissection, not unlike what Dr. Trin described.
Thank you, Sudhir. I think in the interest of time, David, I'd like to just ask you to give us the take-home pearls you want us to take away from this case, and then we're going to move on to our last video. David, you got to unmute yourself.
My major take-home would be is try to do a lamellar dissection if you don't achieve the big bubble. The minimum you'll get is practice. You know, we've been doing this now for many years, and it takes a while to get the feel for stroma. Tanya did a beautiful job on that case, but it's not an easy maneuver, but worth learning, because I don't know about you guys, but my success rate with big bubble is far less than I hear from panel members when I've sat on DALC panels before. And if you're only going to do the ones that you get the bubble on, then you're not going to do too many DALCs.
Okay, so I think the message is keep trying to use the micro bubble technique, cut down. Even if you can't, you can always convert to a PK, and you know worse off. Thank you. I think in the interest of time, our last presenter is Gisela. We saved the best for the end. Dr. Gisela Centella was going to present to us a DMEC on a failed PKP with a combined pupilloplasty. I think, Gisela, in the interest of time, maybe what we'll do is we'll present your case, we'll have a discussion, and then if there's time, we'll do the polls as well, because we're starting to run short of time. Please go ahead.
Okay, so you don't want me to do the first poll?
I think, why don't we just present the case and have the, because there's really good, we've got some amazing cornea specialists from around the world. Let's take advantage of having the talent that we have online. They can't even vote on the poll. So let's take advantage. And if there's time at the end, we'll do the poll, just prioritizing what we're going to do.
Okay, so going back to our videos, for all of us who are really missing the OR, I'm just going to show you one last video of a pretty challenging case of Dr. Rootman's. And first, I'm going to tell you a little bit about the history of this patient. So she's a 60-year-old lady that had a perforation due to a Pseudomonas ulcer. She had to go for a tectonic graft. And after everything was settled down, she went for a PKP and a cataract surgery five years ago. And after those 5 years, her PKP started failing. She came complaining of decreased vision, and she was also complaining about some photophobia and light disturbances. So just give it a thought what type of transplant you would like to choose for this patient. This is the way she looked before we start the surgery. And as you can see here, this is what we decided to do, DMEC and pupilloplasty. So first, I'm just showing briefly the way we prepare the tissue normally with the regular technique we do here. So we do always marker grafts through a stromal window and trephinate our graft, remembering to do this graft smaller than our previous PKP. So once we have our tissue loaded, we bring our patient into the OR and start with a pupilloplasty. The first step, of course, is to try to reduce the pupil size as much as possible. We're injecting some myocol here and trying to free some of the PAS that's there peripherally. And you do see that the pupil does constrict a little bit, still quite large for a DMEC. And that's where we're going to try to close the pupil a little bit more. I just want to show you the technique Dr. Rootman used. He's coming in through his inferior infratemporal paracentesis with a tenoproline that's going to come through the paracentesis, take bites of the proximal and distal stroma of the iris, and then it's going to come outside through the corneal wall, not through a new wound, just entirely through the whole thickness of the cornea. Once we've done that, we cut our proximal strand, and with a Kuglen hook, we're going to externalize the distal end of this proline suture. Once we have that loop, of course, very carefully, we don't want to tear our suture, and once we have this loop outside, we're doing a Siepser knot with a 4th row technique. I know it's a little bit hard to see in the video because we know this type of proline is very, very hard to see. But basically what we're doing is our proximal end is coming around the loop, and that will allow us to do a sliding knot that we can tie without too much intraocular manipulation. And then here, just you can see as we pull both of our ends, we're bringing together the two ends of the iris stroma, and we are able to get a round and center pupil much better to work with for DMEC. Notice that we do have a remainder inferior iridotomy, of course, that we are not going to close. This is our main wound that we're going to be using afterwards for our DMEC, and through this one we're just entering with vena scissors, trying to cut our proline sutures short, of course, because we don't want them to have too much to do with our DMEC. And this was just like a schematic drawing for those who didn't really understand the pupilloplasty technique. This is the Siepser knot that was described a long time ago, and it just shows us how we can tie onto that loop externally outside of the eye, and then tie the knot without going intraocularly. So once we have done that, we're going to proceed with our DMEC surgery. And the first learning point, and I think these learning points are not only for this very challenging case, but for all of us who are learning DMEC, which is the importance of rhodesimatorexis. I know that some of you, and this will create discussion afterwards, would prefer to do a Dissect in this case, and that's okay. And we know that Dissect doesn't require such a vigorous decimatorexis, but if you are going to attempt DMEC under a PKP, you have to make sure you do remove all of Descemet's membrane, as we're doing in the video. Of course, we check with Trypan Blue that we don't have any leftovers of that Descemet's membrane. And once we're sure, we inject our DMEC graft. You notice that we have tried to get this double scroll configuration to try to make it easier for us to manipulate the graft inside the AC. But despite the fact that we have a double scroll, you're gonna see how it really wasn't that easy. And that's why I wanted to bring this case so that we can talk about all these little tricks that will make our DMECs easier. So the first thing that is really making it harder to unfold this graft is the fact that we have the pupilloplasty, of course, and that stitch that we just did in the iris is creating a tent, so the iris behaves a bit differently and a bit oddly, and that's why we're having also trouble to unfold our DMEC. And we're just trying to get it to center better so that we can try to unfold it with our tapping maneuvers on top of the AC. Here we have this configuration that Dr. Rootman likes to call it the folded napkin configuration. And we know that we have different approaches in DMAC for each configuration. So our main advice here would be not to try to unfold this type of configuration, like he's doing here, adding some BSS into the anterior chamber, trying to change the configuration of the graft, because if you keep tabbing on a configuration like this type of fold, you won't be able to open it easily. The graft was also moving towards the incision, so we decided to place a suture. But still, as we tried to manipulate this main incision, you see how the DMAC graft tries to come into the incision. So this is another important learning point for anyone that's doing DMAC. Try to avoid your main incision as much as possible. Having a suture, of course, gives you some sort of security, but still try to avoid using it. Now we have been able to bring the tissue again into the anterior chamber, and he's trying to center it with using bimanual technique. And once he has it centered better, he burps a little bit of BSS or from the paracentesis at supratemporal, getting to unfold the graft very nicely. But here we see that our mark shows us that the graft is inverted, so it's upside down. Here he just does a little bit of irrigation, and you can see how the graft turns around nicely. I want to show you that again because I know it's a very fast movement. So here he comes in and parallel to the iris plane just injects a little bit of BSS, and that makes the graft turn around. So now we know that the graft is in the right orientation. And we continue to get more patients and try to open the graft because it's still very, very challenging. Let's remember that also when you have a previous PKP, the stroma is a little bit more sticky, and that also changed the behavior of the graft inside the anterior chamber. And always think of what are you expecting from your movements? Like, where do you want those fluid waves to take your graft to, not just tabbing in any way, but specifically having an intention in the way you want that fluid to move your graft in the anterior chamber and to unfold it, hopefully. So here, I'm just gonna let it run and show you how all the different attempts we had to get this graft to unfold. And here, it's not fully unfolded, but it looks a lot better. I find interesting this way of using the two hands to keep the graft fixed in one place, as he's doing with his left hand here. And then with his right hand, he's doing the tabbing so that he can finish unfolding the inferior aspect of the graft. Now that we have our graft unfolded, we know that it's in the right orientation. He's still not fully happy with it because it's a little bit decentered, and we know centration is very important. Especially if you have a previous PKP, you don't want overlapping in the graft host junction because this will predispose to detachments. And he injects a very, very small air bubble under the graft, and with intraocular forceps, he's bringing the graft to center it better, bringing it a little bit more temporal. So when we start DMAC, of course, we don't want to touch the graft, and we're very, very worried about touching it. But this is just to show you that if you have enough BSS, and you're very, very gentle, you are able to manipulate the graft with an intraocular forceps. And now the centration is better, but as we centered it, we get this, all these folds that we have spoken about before can, in the first place, can alter the optics and the entrance of the light. And of course, will predispose us to detachments as well. So now what he's doing with the small air bubble is basically ironing that DMAC graft, smoothing out all of those folds. And you see how he's able to get rid of all those folds using the small bubble in the anterior chamber. So this is also an alternative maneuver to get that graft to really smoothen out. And now that we're finally happy with it, we're going to inject the air in the anterior chamber. It's important to remember that we want, in this case, and most of our really complicated DMACs, we want a full air fill so that we have good tension over that graft pressing against the posterior stroma. You see that we have a little bit of leak in the inferotemporal paracentesis, so we're going to suture that as well, because we want that we want to get at the end of the surgery a firm eye with a full air fill. And to acquire this, we use a 30 gauge needle just to make sure that we are able to fill the anterior chamber with air as much as possible. Sometimes it's a good tip to use the 30 gauge needle instead of the cannula because it's sometimes easier to get it to be fully firm. So that was our video. I want to just go over some teaching points really briefly. Thank you for continuing to join us, everyone. So the first tip is to remember the importance of descematolrhexis under PKP and how in these cases we have to be a little bit more aggressive with the descematolrhexis. Remember the behavior of the graft is going to be different because the stroma is a little bit more sticky. So we already talked about that. Remember to try not to use your main wound as much as possible. So as you can see as we saw in the video, even if you have a suture, try not to use that wound. Remember your configurations. Remember not to try to open it despite the configuration. If you're not happy with the configuration, just score some more BSS and get it to scroll in a different way. Yes, you can grab the DMAC graft. Of course, we have to be very careful, and this should be like our last resource when you definitely cannot get the graft to center the way we want it. And of course, at the end of the surgery, remember that to have a firm eye so that the rate of success for the surgery is gonna be higher. And his last tip, which is the one I like the best, is never to give up. So these are pretty challenging cases. Sometimes we start losing our patients, but never give up with anything. Thank you so much for your attention.
Great work, Gisela. Wonderful.
Thank you.
Prof, you've just...
Dr. Slomovic.
Dr. Slomovic, you're muted.
Okay, that was a wonderful presentation. Sorry, I was muted. Wonderful, wonderful presentation, Gisela. And to comment on it, I wonder if I could introduce our most recently added panelist, your future associate, Dr. Carmen Barraquer. Dr. Barraquer, we're honored to have you with us.
Wow. You're muted. Dr.
Yes, thank you.
There you go.
It's a pleasure to see Gisela presentation.
Thank
and
you.
well, I hope she will be back soon enough.
Can't wait.
I can only tell you that we've so much enjoyed having her with us. So I think that she'll do an amazing job when she comes back. David, did you want to say something?
No, I think I said enough today. Give someone else a chance.
Okay. Does anybody want to comment?
Maybe I would like to ask some of our panelists, maybe Dr. Teichmann, if you would prefer to do a DSEC in this case, or would you still try to close the pupil and attempt a DMAC? What are your ideas on this?
Yeah, no, great question. I do a lot of pretty complex anterior segment reconstructions combined with transplants, and I have my sort of set of rules. I love DMAC, as you know. I do tons of DMAC. Most of my grafts are DMAC, but I do, some cases are better DSEC cases. This, I actually have to say, this looked like a pretty good eye, like other than the pupil defect, which we'd repair regardless of which type of EK we were doing. And then post PK, again, I've had pretty good results. But I think specifically for this case, I think I'd probably do exactly what you did, which is a DMAC. But definitely I have for the combined aphakic analytics that aren't going to have a lens put in and stuff, I go to DSEC pretty quickly with a safety suture. I think that in the end it's probably less traumatic. And then there's a paper out of Toronto, right, saying that the outcomes are actually better in very complex size in DSEC opposed to DMAC. So.
Yeah.
Guillermo, any comments?
Not really. Excellent presentation. Just get the video. I'm back seeing a couple of emergencies, so sorry about that. I had to block things. No, excellent presentation.
Sorry, we're all envious that you're back at work.
Well, very slowly. No OR yet, so that's why I wanted to be here. Excellent presentation, and a couple of points I wanted to make. I think every time there's I don't have as much experience as many of the panelists in terms of DMEC, but some of the concerns that always happen whenever there's excessive manipulation is the extra generation of fibrin, which also could preclude the graft from opening in the proper way. So I think the nice thing here was that the manipulation on the iris was very gentle, and and probably that allowed the graft to ultimately open. I also liked the approach in terms of that fold or napkin, or sometimes called origami configuration. And I have done the same thing. I sometimes it's you know, you're there, you're trying to be very gentle, and sometimes you just have to just give it a good flush, and it just magically opens up. And so it's I find DMEC very, very stimulating, and I think we have to push ourselves for extra cases like you guys did in this particular case. I have done a few under PKs, and I think they work well as well. And so congratulations on the case.
Thank you. Actually, one of our polls was going to be if you guys think that if we needed rebubbling or not, because we know that DMEC has a higher rebubbling rate, and fortunately this patient did not need it, but we know that it could happen, and even with rebubbling, they do really well.
Mm-hmm. Yeah, good job.
Sonia, buddy, do you have any comments?
I have a question for David on this case. I know that you don't routinely like to use an inferior PI in these cases, and you had one kind of made because of the the pupilloplasty that you did. In this case, if you didn't have a PI, would you do a PI preemptively to prevent pupil block?
Probably not, because we look at all our patients 2 hours post-op and send them out with a full air fill, and it's pretty easy to manage the air situation at that point. So it was great that we had it. It's one little extra positive thing we had going for us in that case, but normally I wouldn't.
Maybe I can make a couple of comments, starting out with a question for David. How many years into your DMEC experience did you develop the intestinal fortitude to do something like this?
It's not intestinal fortitude. It's a matter of not having enough brains to know when to do something a lot simpler. I think I became so enamored with DMEC when I started doing it that my goal was to try and eliminate the S from my vocabulary. And I've since backed off and learned that there's still a few cases where DSEC is probably more appropriate. But so I would say after a year or two of doing DMECs, I started to tackle the more difficult cases.
So let me make a couple of comments. First of all, regarding Dr. Chu's question, even though many of us will do an inferior PI in routine DMECs, these eyes, the ones that Gisela and David showed, usually behave as unicameral eyes. And in my experience, despite the performance of a good iridoplasty, air migrates posteriorly frequently, especially most of them have large capsulotomies. So I don't think a PI is necessary. Although if you're going to check them 1 or 2 hours afterwards, you will know immediately if the eye is tense and there's still a 90 to 95% bubble, you can burp some of it out. Obviously, you want to burp less out than you would with Dissection. So I completely agree that a PI is not necessary. Dr. Livni made a comment about on the chat about the length of the rabbit ears on the iridoplasty suture, and his concern, and I completely agree with that, that if your rabbit ears are short but not short enough, they can interfere with the unscrolling of the graft. And there are other things that interfere. I mean, you have many things there that are interfering with the unscrolling of the graft, but there's no reason to add that other thing. So he suggested leaving the rabbit ears long and flat on the iris, which is one way to deal with that. Now, Gisela, you used the word fourth row and Siepser in the same phrase. Now, you may have done fourth rows, but if you are referring to the fourth row technique that Amar Agrawal has been suggesting for the last 2 or 3 years, that is in a way an alternative to the Siepser knot. It simplifies it a little bit.
Yeah.
I think one of the most important comments is being very careful with the main incision and not to use it to inject really anything. air or fluid that will then invite the tissue to come out of the main incision. I also like to remove Descemes off of a failed graft. Many people don't. Actually, on our service, most people don't strip Descemes membrane. I like to remove it. I think my gut feeling is that the graft adheres better to, let's say, the pre-Descemes layer or a posterior stroma than it is to Descemes membrane. And the one thing that I didn't pick up on, and maybe you covered it, you or David can comment, was your graft, was your endothelial graft larger, same size, or smaller than the failed PK? Thank you.
Always a little bit smaller than the PKP. We don't want it overlapping that graft host junction, so always a little bit smaller.
Thank you.
Excellent comments. I think in the interest of time, we've gone for 2 hours, so I appreciate everybody's comments. I want to thank our fellows for all the work they did in putting these cases together. I'd like to thank our guest faculty from all over the world, really. Your comments and your insights, sharing with us, have been most appreciated and very educational. I'd like to thank all the participants, our former fellows and guests. And I think, Amrit, we want to end with the last two polls to see about what we should do with this moving forward. Whether we should, we do this on a smaller scale. Is there value in continuing this format? At the max today, we had over 125 participants. So, Amrit, can you put the first, so in order to accommodate most time zones, once clinics and ORs are opening up, we're suggesting having these rounds on a Sunday, which allows Europe and the Middle East to join. Either 9 or 12, probably, actually the best time isn't 9 or 12. The best time would be around 12 or 1, which allows the West Coast to join in, as well as Europe and the Middle East. So would you guys want to see more of this happening, and would you be willing to give up? I think we'd have to cut it short during the year. We'd make it an hour, maximum hour and a half. So please vote yes or no. Okay, so we will call it an end to the poll, and we have, well, you know, we've got 98% saying they'd like to continue this. And if the person who doesn't want to continue it can speak to me after this, I'd appreciate. No, I'm just joking. Okay, so there's one more, I believe, right?
Yes, there is.
Okay.
I'll launch that.
Okay, so this is the other one. If you were, for the 98% who wants to do it again, and is willing to give up an hour or hour and a half on a Sunday, what would you like to see? Quarterly, 3 times per year, twice a year, once a year? Okay, so let's call it there. And we're looking at the majority would like it quarterly, with some wanting it 3 or twice. You know, the other thing is if we do this, we'll have to see with the fellows and the faculty but I see there's interest in having this done moving forward. One of the things that we shared the results, right? Okay. One of the things also is that if we do go ahead and run this on a, do this again on a Sunday, I'd be most interested in hearing what the Cornea group, really our target audience is focused at cornea subspecialists, what they'd like to hear more about, whether that be you know, we're also looking at maybe having some case presentations as well. So feel free to write to me and let me know what you're interested in hearing more on moving forward. Once again, thank you, everybody. And I wish all of you a safe time in opening up the clinics. I welcome you all back if you're interested. We are having COVID-19, what it looks like to open up the offices next Friday, 12 noon. If you want the link, email me and I'll be happy to send it to you. We will be having an international audience for that as well. That brings us to closure.